Hello and welcome to another edition of the Osteopathic Lyceum podcast. As I've done before, I'm looking into the International Journal of Osteopathic Medicine. There's an article that caught my interest that is in print at the moment. The article is entitled Professional Skill Priorities, Comparison Views of Osteopathy Industry Professionals and Osteopathy Students. This was published on June 5th, 2024. The thing that I'm going to do here is read through this. This is really an education intervention, and it's looking at the outcomes. Now, it must be understood that this is qualitative. Now, just because it's qualitative doesn't mean it's not identifying things in a positivist or post-positivist viewpoint. And a positivist or a post-positive viewpoint would essentially suggest that there is a singular reality that can be identified with appropriate experimentation, but the observer is always the challenge, whereas qualitative work is usually considered constructivist, and that would suggest that the truth is dependent on the individual, their previous experiences, and the environment of observation that is currently being experienced. I think experience would be a reasonable term in the clunky way that I attempted to say that. But anyways, it is not immediately obvious if this is more post-positivist or if this is more constructivist. There are a few things that they say in here that suggest it's a little bit more constructivist, but there's a few things that say it's a little bit more post-positivist. So it's not as clear, and that's not going to matter to most of you. But this gives me the opportunity to point to some very, very straightforward things with respect to education and with respect to looking at education interventions. So something that I will say is that instead of telling you a bias, because nobody can tell you their biases, it's not possible, because a bias is a mistaken thinking that somebody doesn't know they're making, whereas a preference is something that's identifiable and the person can tell you that they would choose it over another thing were given the opportunity. So very, very simply, with respect to education, my preference is to utilize a cognitivist psychology or a cognitive psychology approach where the details matter. You will hear arguments in varying places that say that education, or that certain education approaches are indoctrination. I would go so far as to say that all education is an indoctrination. It depends on how you use the term indoctrination, but essentially you are becoming accustomed to and acclimatized to very specific details that other people, whether implicitly or explicitly, agree that are required to do the outcome task of the education. So depending on the particular thing, the detail will vary, but as a framework, you need specific details and to behave in particular ways according to the explicit or implicit agreement of a group that is already doing that thing or has some say in how that thing will be done, whatever it is. So I'm going to read from this paper a little bit and I'll make a commentary. And where is reasonable, I'll talk about other things. Also before that, so my preference is a cognitive psychology approach, especially with respect to education. My second preference is that the actual fundamental intervention within osteopathic manual practice, not in America, everywhere else in the world, because it is a hands-on only practice everywhere else in the world. My fundamental preference there is that we should, as a hierarchy, put the technical skills on top. Now, those technical skills are driven heavily by the barrier concept. The barrier concept includes paying attention to how the patient is responding to the physical intervention, which means that the patient is at the center of all things, but it is their expression of discomfort, pain, protective mechanisms that will guide it. You're trying to avoid those at all costs, so the patient is centered with the barrier concept, but physically, which will often, people can argue that that could be psychological or emotional expression identified through physical means. But what I would say is that a cognitive psychology approach on the education side and a technical skill approach on the osteopathy side, because in that technical skill, as the top of the hierarchy, the barrier concept must be in the middle. The patient is in the middle of the barrier concept. It is not the practitioner. It is not in any way their preference for systems. It's always the patient, if you're doing it according to the barrier concept. So if you pop the barrier concept to the top of your hierarchy with the technical skill set, then that means the patient is up there and their response to the actual physical intervention is there. So those are my general preferences that you're going to be able to consider when I'm talking about this particular article. So I'm going to read. You don't see this on the screen. That doesn't bother me because you can go find the article. As I said, professional skill priorities, comparison views of osteopathy industry professionals and osteopathy students. And this is from June 5th, 2024 in the International Journal of Osteopathic Medicine, which is interesting because they somehow have the URL Journal of Osteopathic Medicine when there is an actual Journal of Osteopathic Medicine from the American side. I don't know if it's the AOA or the AAO, but it's one of them. Anyways, I'm going to read here. 1. The introduction. A primary obligation of university programs is to graduate students work ready for their chosen profession. Healthcare students are expected to develop a discrete skill set over the course of the program of study. A tertiary curriculum should be designed to foster and consolidate incremental development of skill sets to a standard equal to or better than those with years of professional experience. So I want to pause there, that last sentence, although I'm reading fast. A tertiary curriculum, so not a primary, secondary, but a tertiary curriculum, so one that's sort of to the side, should be designed to foster and consolidate incremental development of skill sets to a standard equal to or better than those with years of professional experience. That is a very strange statement. That statement says that somebody who just walks out of an educational setting should be equal to or better than a seasoned professional with respect to particular skill sets. Now, you can make that argument on specific skill sets. So if, let's just say, a seasoned professional was not taught certain skill sets or certain details, yeah, sure, the novice can look better. But with respect to outcomes, especially in the care of the patient, if you use the appropriate measurement approach, the expert will be notably better. So I've spoken about this before, checklists. So, did thing A, did thing B in a particular order? Novices will always look better. They're closer to being evaluated that way, so they behave that way. Whereas experts don't look good on checklists. They tend to look good on global rating scales. Global rating scales are sort of looking more at a hierarchy of outcome behavior. So did they get this outcome? This is maybe a clunky way to describe a global rating scale. An expert will always look better there. The expert learns what not to do on the checklist and what to do and when to do it. So the novice will always go through all the steps. The expert will generally go through the steps when required. So the error of the novice is usually the error of interpretation, whereas the error of the expert is usually the error of omission. There's things that they don't do. But it depends on what's at the top of your hierarchy for what you're looking for as behavior. If you're looking for step-by-step, then the novice will look better. If you're looking at outcomes, the expert will generally look better. So that's a weird statement, and it suggests to me that maybe they don't know that piece of information with respect to assessment and outcome and how they tie together. I think some people know that. I think a lot of other people, I think most people don't know that or haven't been exposed to that. And that could even be an error in my thinking, but that is where my thinking is going to take me. Anyways, to continue to read. Additionally, the onus lies with the teaching discipline to develop curriculum suitable to nurture and grow the ethos, knowledge, and skills necessary to meet the demands of a strategically forecasted future profession. So, future prediction is not the most developed skill in anybody. It's not an easy thing to do, and it requires cultural coercion in order to instantiate it. So I think in the future, people are going to need this thing. And if I'm wrong, I'm still going to force people into that with detail-oriented teaching. So if I'm wrong, then I've taught these people wrong for multiple years because I have to sort of force it in. Now, these people may not be thinking that. These people may not be even in touch with that concept, but the way that that would actually work in practice is you must make a choice that this is what we want people to know. We think they need to know it, whether they need to know it or not, because we can't actually predict the future properly, but we think this is it, so we're going to force them into it. I happen to have a bit of a problem with that, but I understand it from the point of view of attempting to nurture a profession. You try to kind of bully it in the direction you'd prefer it to go. I don't like it, but I get it. To continue to read, an integral aspect of the university's commitment offers opportunity to the discipline to shape the forthcoming identity of the profession. See? Bully, shape. I would equate that to bully. That may be my preference for what I would term an American viewpoint of I will choose and you will not choose for me. That may not actually be American, but it's the way that I view it because my father was from Detroit from a particular time. To read again, consequently, this demands the development of a prospective curriculum which may not necessarily align with current attitudes and industry trends. Again, so maybe they're not thinking they're going to bully, but maybe they recognize the problems that the industry may not want this, but they need it. The university is going to give it to them. So that's cultural production, or that could be described as cultural production. Cultural production requires coercion, good, bad, or indifferent. To continue to read, the osteopathy profession. That's clunky. I'm going to pull out a reading. The osteopathy profession. I think somebody should have edited that better. Should be the osteopathic profession. Anyways, to go back to reading, the osteopathy profession, like many manual therapy healthcare professions, places a premium on the development of professional skills essential for effective patient care. Core competencies of manual therapy professions such as osteopathy not only include technical clinical expertise, but also a range of communication and interpersonal skills vital for fostering patient-centered care. So far, I don't think anybody would have a problem with this. Fair enough. Yeah, you need to have good technical skills and you need to be able to talk to your patients. You need to be able to communicate with them. Continuing to read. This study investigates the student's journey from becoming a practitioner as the curriculum shifts from being an informal hidden curriculum to a formal explicit one. Perspectives about professional skills priorities from industry professionals who have experienced the dynamics of real-world practice are used for comparison with the students who are in the process of acquiring the knowledge and skills they will ultimately require. So I want to make a quick note, hidden curriculum versus explicit curriculum. There is definitely a lot of discussion within health science or health professions education about the hidden curriculum. The hidden curriculum concept tends to live a little bit more on the constructivist side. You take that to mean what you take it to mean. But I can say that observably it tends to live a little bit more on the constructivist side that values the experience of the individual, the individual, centers the individual, the previous experiences of the individual, and the current environment of observation. So it tends to be a variable truth, which means it's harder to get to any form of agreed upon approach or agreed upon quote unquote truth. You take that to mean what you take it to mean, but that's definitely more of a constructivist thing. So that gives me a bit of a clue that maybe these are accidentally constructivists, but maybe they think they're positivists. Maybe they haven't thought about it at all. I'm not actually sure from this. Blah, blah, blah. I don't need to do that. What I will do is read again from a paragraph a little bit lower. So I've skipped some. Obviously, I am picking and choosing what I am reading to try to build a case. I don't absolutely need to read the whole intro and background for you. So I will read here. Historically, accomplished osteopaths have prioritized consummate clinical skills in manual therapy technique first and foremost. The utilization of touch in the clinical encounter was combined with osteopathic philosophy principles and biomedical knowledges and practices from the 19th century to inform treatment approaches. I will pause for a moment. When they note that it was from the 19th century, they don't necessarily note the continuum of information and change in practice and culture. It seems like they're attempting to set something up. Maybe they are, maybe they aren't. Almost all academic writing is definitely highly motivated writing. It's motivated towards a certain outcome. You can like that or you may dislike that, but you should at least know that it occurs. So anyways, as I said, my preference, if I note my preferences, cognitive psychology as an educational approach, and the high level of technical skill, which would center the barrier concept within osteopathy. Okay, to go back to reading. Embracing this traditional beginning, osteopaths today continue to hold in high esteem the need and desire to possess experts manual therapy hands-on skills, which are intricately linked to the profession's identity. Although there has been a seismic shift away from the biomedical model of care to a biopsychosocial focus in the past 20 years or so, educational institutions and allied healthcare have been slower to adapt, and subsequently the advancement in more contemporary perspectives about what an allied health professional requires to be an expert appear immature. So I need to use the term axiology here. Axiology is the value and value judgments of the researchers. These researchers value the biopsychosocial model and they diminish the biomedical model. Think of that what you will, but they are showing you where their values are. If you're reading this with some form of eye that has particular pieces of information that allows you to pull this out and highlight it and tie it together. So these people are very interested in the biopsychosocial model. I've made the argument about the biopsychosocial model that it literally does nothing whatsoever for osteopathic intervention aside from telling you when your actual skill set, which is central to the profession, which is the hands-on skill set, is unlikely to give the patient what they're looking for. It doesn't mean you didn't do your job properly, but it does mean it's not going to give the patient what they're looking for. The biopsychosocial model centers patient experience, so it is a constructivist approach. It doesn't mean that it has no value. It absolutely has value. The patient should be respected. Osteopathy, I would argue, contains this in the form of the barrier concept if you're using it in the way that I would describe it, which is don't make the patient say ouch, which means you have to pay attention to how they're responding to the physical interface that you're having with them. And you also have to encourage them to talk and to tell you when they feel like they need to protect themselves, okay? If you don't do that, I think you're doing the barrier concept wrong. And I also think that the values of these researchers are at odds, and they note this, they are at odds with what the profession currently centers or appreciates or values. So they're noting the tension between what they think should happen and what the profession sort of feeds them, at least superficially. Also, to be an professional requires, yeah. Subsequently, I'm just going to read this again. And subsequently, in the advancement to more contemporary perspectives about what an allied health professional requires to be an expert, appear immature. So it's sort of a academic technical dig at osteopathic practice. Now, I make those, but I think this one is misplaced. Anyways, deeper learning is, no, man, they don't know anything about learning. Sorry, that's disrespectful, but whatever. There's just a general statement about how you develop educational interventions based on theoretical approaches. So you need a theoretical framework. You must also understand that a theory has to be called a theory, should have withstood attempts to falsify it or attempts to break it, and it should not break. But that's not necessarily discussed here. Blah, 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 blah. Clinical communication skills. So I'm going to read here. Clinical communication skills are purposeful and nuanced healthcare skills aimed at fostering collaborative partnership with patients in clinical settings. These skills involve actively listening to patients, being sensitive to emotional needs, and sharing clear, concise, and accurate information and messages effectively without using medical jargon. There is no longer ongoing debate about whether clinical communication skills should be explicitly taught or left to develop implicitly as soft skills generally are. The shift towards patient-centered care suggests relying solely on students' natural inclination for skill development throughout their tertiary health science program is insufficient. I'm completely okay with saying that you shouldn't leave communication skills to develop implicitly. I'm completely okay with that. What I will say is that there is an assumption that I do not think the authors know that they've made. I've spoken a lot about the theory of constructed emotion from Dr. Lisa Feldman-Barrett. Essentially, there are sensory data from the body to the brain that are interpreted, and then they will be given a category word, and the actual expressions or descriptions of what falls under those category words have a wide variety of presentations. So there is no single anger, there is no single happiness, there is no single joy, there is no single love. So those are category words under which a variety of people will give you a variety of explanations. You'll have a range, but it will be very different. So emotions are not a stable category. They have stable category words with a wide variety of presentations. So being sensitive to the emotions of others is actually much more complicated than one would think. If you assume that you can read emotions in others, then you are actually being culturally insensitive, because people from different points of origin will have very different cultural intermediations as ranges of emotional expression. There are places in which certain facial expressions do not mean the same things as in other places. So if you like culture, if you like the subjective experience, then to say that you should be able to train somebody to identify emotions means you don't understand how many details somebody would actually have to know to appropriately be sensitive to the wide variety of expressions that will show up. So there's a very, very strong challenge to the assumption that that's going to work that way. I think you can teach communication skills because you can generate a variety of circumstances, and you can tell them the framework such that they can apply that framework and alter the details in many situations. Obviously, I also have a far transfer paradigm preference with respect to teaching, especially teaching to people who will see a wide variety of presentations and need to interpret them. Again, so that's another preference to let you know. So yeah, I agree you should explicitly teach communication skills. I don't agree with what these people are absolutely saying. Blah, 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 blah. I'm going to go down to the results, so please excuse me as I scroll down. Results, 4.1. Yeah. So I'll read this portion. Over a 3-year period, 6 focus groups, each approximately 60 minutes in duration, were conducted exploring osteopathy student perceptions. And that should say osteopathic students. I return to reading. Attitudes and experience about patient-centered care. A total of 23 students participated, representing 3 different cohorts with varying explicit communication curriculum interventions. For comparison, semi-structured interviews were conducted with 8 industry professionals, each lasting approximately 45 minutes in duration, and explore the perceptions, attitudes, and experiences about the priority skills needed by an osteopath to provide patient-centered care. These interviews were undertaken in the subsequent 12 months following the final data collection from cohort C. So it's a qualitative approach. The numbers are smaller. They did not say that they reached sufficiency. Sufficiency is a term whereby you are going through your interview process and themes are sort of coalescing from that process. You're finding the same thing over and over again. And at the point where in the next interview you find nothing new, and like there's nothing new showing up as information, you've reached sufficiency. So the numbers can be much smaller. They didn't say they reached sufficiency, so I would have to assume that they did. So that's why you see 8 industry professionals instead of 28 or whatever. Hopefully they reached sufficiency. I don't know. 4.1, major themes. Predominant themes were identified following collation of all codes for cohorts A through C and industry professionals inclusive. All associated subthemes have been cohort stratified to support and provide context to the narrative of what worked for who, where, and in what settings. Blah, blah, blah. Yeah, that's the themes. So 4.1.1, clinical skills. So I'm going to read this. Clinical skills and clinical knowledge are considered essential to the professional practice of osteopathy. Without them, there is no service to offer. Cohort A, who did not have opportunity to engage with explicit communication curriculum, interventions commonly reference clinical skills to involve manual hands-on actively doing to the patient skills such as assessment and treatment. The sentiment is largely aligned with the industry professionals who, when asked to think back to prior to beginning their osteopathic careers, also cited hands-on skills to be essential, including diagnostic assessment and clinical reasoning. Please refer to Table 3 for detailed quotes, blah, blah, blah. Going to continue to read. Cohort B, who had an opportunity to engage with advanced communication curriculum, also referred to clinical skills, including manual hands-on abilities, but broadened the proficiencies to include the capability to ask case history questions and explain a working diagnosis. These 2 additional subthemes concurred with the industry professionals to explain case history taking and working diagnosis to fit within clinical reasoning. Please refer to Table 3 for supporting quotes. Interestingly, as per the limited data available, Cohort C, who had opportunity to engage with a complete communication curriculum, did not include any manual hands-on skills within the clinical skills category, but rather referenced communication and rapport as essential skills needed to practice osteopathy. These 2 subthemes more closely align with what industry professionals acknowledge on reflection as essential skills needed to practice osteopathy, but did not consider as priorities prior to graduating and working as osteopaths in the industry for years first. So what I'm going to say from this, cohort A, no communication intervention, hands-on skills, right? So the details that they received, hands-on skills, did not receive communication details in their education. That supports the cognitive psychology approach that details determined thinking. So if you don't have a detail, you can't think with it. Okay, cohort B got hands-on skills and some communication. That lines up with sort of the industry professional saying that both matter, but the idea is that they started to include it in their clinical skills. Whereas cohort C said, oh, it's all the communication skills because they got the full curriculum. So this is going to line up with what these authors are saying with respect to the university driving the professional identity. And they're lining it up with the professionals reflecting and saying, yeah, you know what, the communication really matters. So the implicit development gets the professional to the point whereby they value communication with the patient. The explicit development means that at least superficially, the student downgrades the technical skill and says the communication is important. So you're looking at the expert outcome. So the expert over time says communication is really important. The student, and the expert says that when they were new, they thought the hands-on skills were really important. and they are. If you're trying to line up with the expert outcome, you're missing all the steps that get them from novice to expert. I would argue that the point of an educational curriculum for a healthcare professional is to produce a good novice who can become the expert. I do think you should have an explicit approach to teaching communication skills. But if you teach the communication skills and the student tells you that the communication skill is the most important clinical skill, or the clinical skill that they value the most, then you may be shortcutting the development of their hands-on skills such that the communication skills can support them appropriately. So just because I, as an industry professional, say that communication skills are the most important thing doesn't mean that I'm right. It just means that you asked me. So if you ask my opinion on something, I give it to you. If you don't couple that to outcome data, you don't know if it's as valuable as I say it is. You're asking me about my feelings. You're not asking me about my outcomes. What I would suggest is that one of the major flaws in this approach is that they did not attempt as a baseline to figure out what the most important thing to patient outcomes is. Now, I've told you what my preference is. My preference is the actual technical skills, but the actual technical skills include the barrier concept. So it's almost like both of these sides are there, because to use the barrier concept, you have to have good communication. You have to be able to tell the patient when to tell you there is a problem that is going to get between you and the treatment outcome, between the patient and the treatment outcome. So the patient feels like they need to protect themselves from what you're doing. They need to tell you, communicate with you that that's happening. So you as a practitioner have to have good communication skills. So what I would actually suggest is that you should really teach people how to communicate around the barrier concept. Tell the patient when they need to tell you things, or the types of things that they need to tell you as a practitioner, so you can get the best outcome for them in a predictable, consistent fashion. They've done a good job so far with this article to support their priors. Their priors are that communication is the most important thing, that the biopsychosocial model is the center and the be-all, end-all. I don't agree at all. They've done a good job getting there. Whatever. I'm going to read this briefly. 4.1.2, communication. All focus group and industry participants acknowledge communication to be a critical element in the clinical encounter. Cohort A, who were not given the opportunity to engage with any explicit communication curriculum, mostly refer to communication skills in clinical healthcare setting as those used in everyday basic communication skills, such as verbal, nonverbal, and listening skills. Cohort A referred to clinical communication skills to be mostly about giving information as highlighted. Cohort B alternatively referenced communication in a healthcare setting to be skills commonly associated with asking questions to take case history and giving information as part of the process and seeking informed consent. Please refer to Table 4 for detailed quotes. As per the limited data available, Cohort C, who had the opportunity to engage with the full communication curriculum intervention, discussed communication in the clinical setting to be interlinked with PCC, patient-centered care, and the giving and receiving of information. Cohort C's responses closely reflected the industry professionals who cited communication in the clinical setting to be quintessential to a clinical consultation, as is shown. So you can see there's some motivated reasoning here. They're starting to line things up. I totally understand it. I totally get it. I just don't know that they're appropriately investigating what really matters for the patient outcome. There are going to be a lot of research arcs available that ask patients if they liked stuff. And it's very important. So there is what I would call a customer service element to a lot of healthcare and a lot of education. Did you like it? Did you like the way this was delivered? Did you like the way this was received? It matters a lot, but I don't know that it actually is the outcome that you need to strictly measure with respect to healthcare. So I'm going to take that as an opportunity to break. I just have to do something really quickly with the memory card. One moment. So returning to the concept that patient outcome, asking the patient if they liked it. That's a customer service construct, or I would call it a customer service construct. That may not be the outcome that you really need to measure with respect to what is the best outcome for the patient clinically. It is part of it. If the patient did not like the process, if they did not like the way that they were interfaced with, then there is a legitimate problem. But if we're talking about certain types of outcomes, like more urgent outcomes, it's probably inappropriate to look at it that way. It's probably much more appropriate to look at whether or not the urgent measure changed. If the urgent measure is a ventilatory issue or a blood pressure issue, right? So let's just say somebody is literally leaking hydraulic fluid or they have an arterial bleed. Customer service is not the thing to measure there, right? Patient satisfaction is not the thing to measure when somebody has an arterial bleed. It is, did you get them in time to save their life? If a patient has an acute range of motion issue that would appropriately respond to osteopathic care, there is going to be some degree to the way that you treat them as a human being, how you interact with them, how you communicate them, should not be off-putting. But that is the construct that should be put lower than this thing does not move right now and it's a problem. Like it's a real problem, say for activities of daily living. So the constructs can move up and down in the hierarchy depending on the nature of the case and the case in that moment. So that's, say, more context-based. It's more centered around the patient's actual needs as opposed to their preferred needs. So their expressed needs as compared to their preferred needs. And there's different ways to say that may be more appropriate in terms of technical descriptions, but that's the way I'm saying it for now. My preference is that you bring me roses when you treat me. My need is that my shoulder doesn't move at all, right? So if you don't bring me the roses, but my shoulder now moves, I can have a negative report about you, but you can do your job exceptionally well. So because now at the end of it, my shoulder moves. This is a consistent contention because there is a degree to which to be able to approach healthcare, you can't be a jerk to the patient. The patient actually needs to be able to approach you as a human being. So your soft skills do matter, but if your personality does not allow you to have the soft skills that would allow you to interface with a broad range of people in a way that doesn't piss them off, well, your personality doesn't have that. You may not be able to teach for that. You may be able to improve it within a certain range, but not teach it to whatever standard. So a patient-centered care model means that you need to respond to the patient. Osteopathy is a hands-on profession. It has the barrier concept. The barrier concept, when utilized properly, means you must always respond to the patient. It also means you must be able to communicate with the patient such that they know what they need to tell you and when they need to tell it to you. So, as I said before, I would teach to that. I wouldn't necessarily teach to a biopsychosocial model. A biopsychosocial model has at the top of its value hierarchy the experience of the patient. It will acknowledge that the biological stuff must be cared for, but it doesn't center it, at least not in the way that people use it. The way that people use it, it's to say, forget about the biomedical approach, think about their emotions and their experience. I get it. I think a good biomedical approach properly includes the experience, the emotions of the patient, especially in osteopathy, because osteopathy, when done appropriately, to the concepts, the underlying concepts that are omnipresent, which one of them would be the barrier concept, requires that you pay attention to the patient and you empower the patient to communicate to you properly. So I think the paper does a good job of what it's trying to do. I don't know if I agree with the job it's trying to do. I don't agree with the biopsychosocial model being the center of complementary alternative healthcare, because at least with osteopathy, it's an obvious hands-on skill set. It obviously can identify when something isn't moving as well as its paired structure. It can obviously, when done appropriately, identify when it's changed. And because of the barrier concept, it can very obviously pay attention to the patient such that you get the outcome. I completely acknowledge the need to have strong soft skills, because if you're a jerk to your patient, they may not be able to approach you for your high technical expertise. I also disagree that trying to train somebody to hit the expert behavior when a novice is inappropriate. I think you should treat them to be a really good novice with a framework that allows them to explicitly approach becoming an expert. That's why I have what I call a heuristic-based approach. There are frameworks that are not tangible, not visible, but are always there, that will allow you to alter details and make decisions based on it, or based on that omnipresent, non-tangible, non-visible framework, such as the table makes stable. such as contact is control and control is safety. So that tells me that no matter what I'm doing, the more contact I have with the patient, the more safe they're going to be, the more relaxed they can be, the more I can appropriately respect the barrier concept and not make them say, ouch. The more I can make them feel safe, the more I can empower them to tell me that they don't feel safe, that they need to protect themselves. I can build all of this with a heuristic-based approach, with a FAR transfer paradigm. So I think fundamentally, a lot of the momentum within the osteopathic profession seems to be going in the direction of a constructivist approach, which is inappropriate for the actual technical skill set. I don't think you should try to teach people at the expert level. I think you should try to teach them at the novice level, because the expert will appear. Going from novice to expert requires obvious identification of errors. Sometimes you need somebody outside of you to identify those errors for you, so you can build a curriculum that lets that happen more, but you can't necessarily teach somebody at the novice level to be an expert. It ignores and does not properly acknowledge the required process for error commission to go from novice to expert, to learn what is valuable and to learn what is less valuable. So trying to make the curriculum line up with what the profession is doing at the expert level, you have to know that you have the right experts that you ask questions to. You probably didn't. You probably had an interesting sample that was highly contextually bound, that may not transmit to other circumstances. Maybe it does, but you don't know that. You didn't tell me if you reached sufficiency. There's a lot of challenges. I think they did the job they wanted to do. I don't necessarily think it's the right job. Yeah, stop trying to teach people to be an expert at the start of the career. Maybe try to teach them how to be a very, very good novice, and teach them explicitly, because it works well for the FAR transfer paradigm, the stuff that it takes to move from novice to expert. And a lot of that is errors, but safe errors. Make them as safe as they can be. Luckily, osteopathy is very safe, because you're not breaking skin. You're not moving too fast. You're not moving in dangerous ways. Some places in the world, they definitely use HVLA, or high velocity, low amplitude thrusts. It's very dangerous. So, generally speaking, osteopathy has a very safe practice profile. Teach people to be very safe. Teach people to respect the barrier concept properly. Teach people what the omnipresent frameworks are for good clinical decision-making, very safe clinical decision-making, and tell them it's going to take them time to get better at things, and that they will be clunky at communication at first. And you can teach them the framework for communication. You can teach them the things that they really have to absolutely have covered, and that they're going to have to change the words and the sentences they use, because not everybody's the same. People are different. So use a FAR transfer paradigm. Use cognitive psychology as a general underpinning approach. Highlight that the actual requirement for knowing that how you communicate with a person matters is a good fundamental hands-on physical technical skill set. Don't teach the communication skill set so that the students obviously downgrade it and upgrade the communication skill set. You're missing the point. The point is they have to be a novice first and think the hands-on stuff is the most important, and then they'll get there. Now, some people would say, well, teach explicitly. You can still do it explicitly, but you need to have that high-level technical skill set as sound as it can be, so that it can evolve over time with the evolving communicative skill set. So once again, FAR transfer paradigm, cognitive psychology as your underpinning, because details matter. The details that you teach really matter, and you can see it, because those who got the communication curriculum versus those who didn't have different viewpoints. So it shows that the details at least matter to some degree in what they express. Asking people how they feel about what they need isn't asking them how they perform or looking at performance data. So be very cautious of that, and stop trying to make people experts at the start. Make them exceptional novices that will evolve into better experts than the experts we have now. So hopefully you listened the whole way through. Thank you very much, and hopefully you learned something from it, and we'll talk again soon.